Hey everybody, welcome back to this week's live stream on Synapse Care Solutions YouTube channel. I'm Kathy Randall and I am glad that you are here for the first of 3 presentations by nurses and nurse practitioners who are going to be focusing on bedside nursing and unit-wide interventions to decrease the rate of IVH. So you're going to hear from bedside nurses, from nurse leaders, and from nurse practitioners on some innovative strategies that they've been doing in their units. So this week we have Jill Beck, a nurse from the United States, and then we have Mazal, Shemer, who is a neonatal nurse practitioner and nurse leader at a unit in Israel. They were at our 2021 conference in Orlando, Florida. So it's really fun to be able to bring these presentations back to you. I hope that you'll find some inspiration in what they've been doing in their unit and realize that you can make a difference in your unit. Start small, start with a project that means something to you, find that passion and move forward. If you haven't already, go ahead and click the like and subscribe button. It helps us out a lot and it tells YouTube to send more videos like this your way. If you'd like to get some of the resources that are mentioned in this presentation or to get weekly reminders from me about these and other events that we hold, go ahead and click the link in the show notes below or scan the QR code here on this screen. That will take you to a page where you can register and be notified for all those things and get access to some exclusive bonuses and other videos that we don't post on YouTube. So without further ado, I would love to introduce Jill Beck and Mazal Shemer.
I am a nurse at Thomas Jefferson University Hospital, which was a delivering hospital in Center City, Philadelphia. And I always like to start out my session with the fact that all of this research, this whole entire QI project was nurse-driven. Yes, we had physicians help us, but most of it was nurse-driven. And Kathy was saying in the introduction how it only just takes one nurse to strive to make things better. And also, I was lucky enough to have a group of us working on this project, but I think that's what stands out the most is this was a night shift-driven project. I am a night shift nurse. We are not elusive. We do stuff, and we can make a difference. And I think that people forget that. So that's why I have to make it out there and give a shout out to all of my colleagues that I worked with on night shift and all of you lovely ladies and gentlemen that were night shift too, because we can make a difference. I know the hospital's 9 to 5, but we do work all shift. I just wanted to shout that out there. Objectives. I'm just going to talk about some risk factors that we see in these very low birth weights to increase their chances for risk of IVH. And then we all know there's a lot of antenatal and delivery room processes that affect IVH. So we'll talk about that and how we can reduce it from the very, very beginning. And then obviously the meat of my talk will be, what's the process? What did I do to implement an IVH reduction bundle in my unit? And also we will get to hear from somebody on a global perspective on how they were able to implement it. It's just that same theme. It's one nurse. We can do one thing, and that one thing can be taken in all different areas. And it's very simple, and it's very easy to implement this wherever you are. No funding was received. Did it on my own, and there's no conflicts of interest. So we're not going to go into the pathophysiology and that part of IVH, but we all know that IVH is bleeding in the brain. And it's a serious risk for very low birth weight infants, and it contributes significantly to morbidity and mortality in these babies. So this is something that we see a lot, and it's something that's very important. We should always have that in our mind. So the pathogenesis of IVH, baby's brains, the germinal matrix, it's very fragile. It lacks a lot of structural support, which increases the chances of bleeding. So these brains, they can't auto-regulate. The cerebral blood flow is constantly fluctuating. And think of all the things that we do to these babies and how we turn them and move them and position them and every kind of procedure that's done on them. That is constantly creating change. And they're getting different blood pressures going up and going down, and that's really increasing that risk of bleeding. Some risk factors are, most frequently, we see them in less than 32 weeks gestation. And the lower the gestation, the higher the risk. And I thought it was really interesting that it's been shown that with each increase in gestational age, you'll have a decreased risk of 3.5%. So you see the older they are, the higher the gestation, the less risk factors they will have for developing IVH. And then obviously, the lower the birth weight, the increased rates. So 20% are the very low birth weight, and then 45% for extremely low birth weight infants. So then our guys less than 1,000 grams. And again, changes in cerebral blood, that was very important. There's a lot of research done on the germinal matrix and how it's responding to cerebral blood flow changes and blood pressure changes. And most research shows that it's most frequently occurring in babies less than 30 weeks gestation and 1,500 grams. And I think the most important factor that I found in my research that 98% of IVH occurs within the first 72 hours of life. The first 72 hours of life. Think about what that baby goes through in the first 72 hours. I mean, 24 hours alone is being in the delivery room. We've all gotten very good at the golden hour and trying to help with that. There's a lot of 72 more golden hours behind there that we need to protect those babies. And then unfortunately, 50 to 75% of those babies with IVH are going to have some kind of complication, such as CP, neurodevelopmental delay, and unfortunately hydrocephalus. So this is why this is so important, because these numbers of babies that are developing IVH are coming out with a 50% chance of having a complication. So I feel like that was something that was really important for us to be sure that we're looking at ways that we can change our workflow and our bedside care to decrease this. We all know the grades of IVH. So you have your grade 1 to grade 4 being the most severe. So you have your grade 1s and grade 2s. We don't see a lot of dilation in the ventricles. These babies sometimes have reabsorption done later, like weeks later when they have follow-up head ultrasounds, and they might not see as many complications, but it's these grade 3 and grade 4 bleeds that go into the dilation of the ventricles. And then we start getting some damage to the periventricular white matter. It's these grades 3 and grade 4 that we're really going to have to focus on. So I talked about in antenatal and delivery room strategies. In the beginning, we thought, hey, if we can start at the delivery room and we can start antenatally, then maybe we can help the chances of premature babies. So we all know we use standard steroid use with the moms in a delivery room. We try to give them betamethasone, which is the most common steroid that we give antenatally. And timing is everything, right? So we want to be able to give this to the moms as early as possible to have the best benefit. But unfortunately, I know all of you that work in a hospital, when delivering hospital, sometimes we can't get it to them sooner. There's a lot of studies that show even just having a 24-hour time period with steroids is beneficial to these babies and does have some better improved outcomes. And then delayed cord clamping depends on infant stability. It's 30 to 60 seconds. Maybe the baby can only survive or tolerate 30 seconds, but as long as we can give some form of delayed cord clamping, that has shown to decrease risk factors for IVH. And also, too, this study was started in 2015 is when I started to get the ball rolling. So in 2015, delayed cord clamping wasn't standard of practice in a lot of places. And it was very difficult to get the buy-in of the medical team, the OB team mainly, and also the neo team, because that's very precious time. And people are nervous to allow that 30 to 60 seconds of delayed cord clamping. So it took a lot of work to get buy-in, a lot of meetings with the OB and the neo team. I did come in during the day for that, but it did take a while. And with any kind of QI initiative project, there's a lot of struggle and there's a lot of moving back before you can move forward. But we had to put a lot of workflow practices in place to make sure that we had warm, sterile towels for holding the babies, even increasing the temperature in the delivery rooms, all these different things, these moving pieces that had to work together to get it. Now it's standard of practice and it's what everybody does now. But back then in 2015, this was just coming to light. So that was a struggle prior to getting to where we are now. I was the co-chair of our unit council, and we usually just talk about nursing issues. And I thought, let's invite the medical team to kind of talk about where we stand or how well are we doing. Because I think sometimes it's good to hear what we're doing is working and how we are actually having really good outcomes, because people are quick to tell us like, hey, you're not doing this right, you're not doing that right, but what are we doing that's successful? And we should celebrate that. And I thought, we just had low morale in the unit, so we'll invite the medical team there. So we belong to the Vermont-Oxford network. So I asked them to share our standings of where we compare to other academic centers. And the results for some things were very good, but our IVH outcomes were awful. It's embarrassing that I'm even showing you guys these results, but we had a 24% severe IVH rate, which is way above what the average is. So that one to me in the meeting stuck out. most of we were baseline with everything else, could improve some things, but to me, I thought, what else can we do? We're already trying to work on things on the units, increasing the delayed cord clamping, making sure we're doing thermoregulation in the DR. What other kind of things? I did a lit review to see, is there any practice, that clinical practice, a workflow in place for nurses at the bedside, maybe because we could create some positive changes. And I really just saw that most of the literature out there was antenatal steroid use, delayed cord clamping, thermoregulation, and it did talk a little bit about environmental factors. So then I thought, environmental factors, we can do something with that. And all we did in our unit really to decrease IVH was focus on admission temperatures and compliance with delayed cord clamping. We had a whole entire bundle they called the icy bundle, which we used to increase our temperatures of our babies in the delivery room and then when they came up on the unit. But that wasn't enough because our rates are still 24%, even though we were doing all that. I thought, I don't really know if the bedside nurses on the unit, do we really know what risk factors there are for IVH and what we're doing at the bedside and how that can contribute to IVH. So I did a pre and post test and I wanted to see what their general knowledge base is. What are they telling the parents too? So do they have an idea even what IVH was? And also do they know what they're doing at the bedside can affect IVH? And it was pretty reflective on what they do. Some people couldn't really figure out the different gradings. They didn't really understand what that meant. And people think that with IVH, a lot of times people think it's something that's going to happen. It's already going to happen, and there's nothing that we can do to prevent it. And then I did get a lot of that. So I knew that this was an area we had a deficiency in knowledge that we needed to work on. And also I figured, okay, so what are some bedside care measures that we can do as a nurse that can help decrease the development of IVH? Going with the environmental picture and the pharmacological picture, I thought head position, stimulation, bed elevation. For bed elevation, I just mean the head of the bed. Circulatory management and education. Because education, I found, was obviously a topic that we needed to discuss of how with the pre and post test. So the purpose was to do a standardized bedside management practice, as well as family and staff education to decrease the risk factors of IVH in inborn, very low birth weight infants born less than 30 weeks gestation for the first 72 hours of life, and decrease severe IVH. So remember earlier we talked about how the first 98% of bleeds occur in the first 72 hours. So that's why I picked 72 hours. And it also worked out well because we were running a whole research QI initiative on the golden hour. And a lot of those kids were less than 30 weeks. So I figured if I can streamline it, make it easier for the nurses, maybe they'll buy into it a little bit better. And my IRB was from January 2016 through December 2017. So that's when the data was collected. So we used the model for improvement, so that's the QI system that I used. And I had a multidisciplinary team, not just nurses. There was nurses, we used respiratory, physical therapy, occupational therapy, x-ray, and different other teams that came together. And we created a fishbone diagram to see what areas that we could improve and where are the knowledge gaps and where are the gaps in the project and how we can improve it. And then once we found out the gaps and areas of improvement, a key driver diagram was created. And I'll show you one, and it works as a roadmap. It helps us direct how we're going to implement this bedside care bundle. And I used a mnemonic, I never can say that, heads up, which means head elevated, always midline, decrease stimulation. Because I figured if you name something, you title it something cute, people are gonna remember it, and they hopefully will want to do it. So it was called the Heads Up. So it's the Heads Up bundle is the name of the project. So here is a picture of the fishbone diagram. And you can see there's 5 areas that we wanted to work on: the equipment, process, people, environment, and management. So when I was telling you about how many things that you don't think about you need that will work together to make your bundle work. For example, equipment. I know you all have broken equipment, and I know everybody rigs their equipment to work better. I know sometimes we have beds that don't elevate, the head of the beds don't elevate, and so we need to make sure that those things are fixed. We need to make sure that all of our equipment's working properly. Is everything in the delivery room working appropriately? And then just the people, too. Think of everybody that touches a baby in the NICU. That many people, all of those people, from the parents to myself to respiratory, the docs, x-ray, all of the different residents that are coming in and out. So all these people needed to be educated on the bundle. And x-ray, because x-ray is coming and they're taking films of our babies. And I needed to make sure that they were on board and they understood what we were doing. So you can see it's a very mobile working project to try to get everything to continue to work together. And once you have all of this standardized and you have that in place, it's really going to make your project drive forward. There was a lot of beginning room for improvement, for fixing some stuff and getting everybody on board and educated before we could roll this out. So I told you about the key drivers for our roadmap. We identified 3 key drivers, and that's going to direct our project and allow for process changes to occur. So decreased stimulation, hemodynamics, and staff parent education and awareness. So here is our key driver diagram. So the aim is always your goal, so my goal, and then your primary drivers, which is decreased stimulation, hemodynamics, and ICN culture. Where I worked, we were called the intensive care nursery because I worked in an adult hospital and there already was a NICU, which is the neuro-intensive care unit. So that's why you see ICN culture. We'll go through these individually, the secondary drivers. So once we've determined our primary drivers and drew out our secondary drivers, then we can start that journey of implementation. Then we can decide how are we going to make changes. Everybody knows about plan, do, study, act cycles. So you plan something, you do something, you figure out what went wrong, what went right, you study it, and then you act. So you might have to make changes. And we did have to do a lot of PDSA cycles for this project, and we found out areas that worked, things that didn't work, and how we can create better outcomes. So I'll show you one of them that we did later. So heads up bundle. So this is going to be our nursing care practice. Nursing care. We're going to elevate the head of the bed. The highest that you can get your bed to go with whatever company that you're using. So I believe it's 12 degrees, 14 degrees. So whatever the highest elevation that you can get. Where I worked, we have older equipment, so we were allowed for a higher elevation. So it depends, but you definitely want to make sure that you have your head of the bed elevated. We did midline position for 72 hours. We didn't bathe the babies for 72 hours. Daily weights with 2 clinicians. So basically, we couldn't get the physicians to not allow us to not weigh the babies for the 3 days, for the 72 hours. So we compromised. So we did a 2-person weight. So somebody had the head and someone had the bottom of the baby, just to ensure that we can maintain proper midline positioning. Q6-hour care, so we clustered our care. And right here, this was a difficult thing because we had to get physician buy-in. This right here is changing everybody's workflow, and nobody likes change in their workflow. So we needed to make sure that they realize the importance of scheduling things around the same time. So we don't have a 5 o'clock x-ray, 6 o'clock labs, care at 8. So we wanted to make sure that they were aware, the physicians were aware too, when they were going to come in and coordinate our care with when we needed a lab draw or an x-ray. Of course, x-rays come up. Something's going on, you need to get an x-ray, you need to get an x-ray. But if it's just a daily x-ray or daily labs, morning labs, routine, then let's try to cluster that together. Parent holding. When I sat through IRB, they had a really hard time buying into this because they were really hung up on parents not being able to bond with their children. And again, I work at an adult hospital, so they didn't really get NICU stuff, but there's other ways to bond. So we taught parents like calming touch, different ways that they can bond with their babies without having to hold them. And I think that it did work because I think when they understood what we were doing and these 72 hours were so crucial and so vital that they were okay with it and they didn't really mind that they weren't holding the babies because we were giving them other ways to bond, even if it's oral care, reading, calming touch. So that's where we had the physical therapists and occupational therapists really help us out a lot with teaching the parents techniques to do at the bedside when they were visiting. Hemodynamics was something, which is our second driver. That was something that was very difficult to streamline. The medical team didn't really all have an agreement to what they wanted to do. So we really had to make it a discussion in rounds. We discussed blood pressure management with every baby that was in the bundle and talked to them. And these are the things that we were looking at. Hazard perfusion, do they have good urine output? And we wanted to make sure that we got a stable blood pressure because again, I told you, we don't want to have these great shifts in blood pressure. If a baby's got very low blood pressure, does the baby perhaps need bolus? Do they need blood? These kind of things that we talked about together in rounds. And then we made sure that people weren't pushing their boluses too quickly, and everybody was giving it slowly, because that too can cause IVH. So this was a lot of an educational piece for the staff as well. So remember I told you about PDSA cycles. I wanted to make sure that we were really monitoring our intake and output, our INOs and our babies, and we're not giving these patients too much fluid or too quickly, because that can really change the cerebral blood flow. And I wanted to make sure that they were documenting it. So I can to make sure that they're giving them the minimal amount of fluid. So when I implemented this and I was watching people, and I don't know, I saw everybody, I walked around the unit, some people would flush a medication with 1.5 cc. Some people would flush it with the whole 3 C's flush. So nobody really had a standardized flush, how much to put through it. And also, too, some people were putting the flushes very quickly. And I don't think they realized, and I did find out that they didn't realize by the results of the pre-test that I did, you need to make sure that you're not slamming you see people take an ART sample out of a UAC and they push the flush it real quickly. Like, you can't do that. I think that there's a way that we could have made it better. So I put together a kind of a way that they can monitor how much fluid they need for each different kinds of IV catheter or UA, UV, whatever, to really streamline it. So everybody's doing it the same. And it determined that we were all giving the same amount for any patient that had it. These cards were there at the bedside. So the nurse can quickly see, oh, they have this blue clave on, this PICC line, and this is how much flush that I would need to put down. So that was the result of a PDSA cycle. And this was our checklist, our bedside checklist. I didn't really want to do a checklist at first because everybody hates filling out checklists, and it's another workflow addition to people. But I found out that after doing this for a little bit, a couple weeks, people were confused. What do I do? Who does this? What is that? That's another PDSA cycle, so I developed this checklist. And I worked at Jefferson. So Jeff was our mascot, and every isolette had a Jeff head on it, haha, heads up, and we would write on the head when the time was up for heads up, so when the 72-hour mark was over. And it was cool because I think a lot of the parents were really excited, and they were counting down the time that day would come where they could maybe hold their babies, or hey, they just beat a milestone, the first 72 hours. So everybody had the head of the bed, the Jeff head on their beds with the date and the time for their thing to be over. And this checklist basically has everything that was included in the driver diagram and just marked out. So that way I can not only make sure that people remember what they need to do and what's included in the bundle, but I also can monitor compliance, because I want to see what areas are we failing, what areas could we improve. So that's why this was a good way for me to really drive my PDSA cycles and different things that we can make improvements on, or small adjustments to see where we were lacking. Obviously, sometimes some of them aren't all going to be completed. There's not PT/OT consults on night shift. It was a good way for me to do tracking and compliance. So here is how the change in our nursing practice worked out, to see a visual. So you can see how horrible our rates were. In 2015, the lowest we had was 12.5%, but we were really hovering in the 20s for quite some time, for some quarters. It was definitely something that we needed to do. And you can see, since we started our implementation, our IVH rates for severe IVH dropped drastically. I love a run chart. I'm a data dork. I like research and stuff, but this is an awesome way to very visualize what we did. So I told you, we started doing delayed cord clamping, and our IC bundle was introduced, which was thermoregulation. Let's try to keep these babies warm. And then we started, so you can see we have those really high level. Grade 5, I just put that up there because that kid had like really bad PVL, so it was like a way that I could, it's not really grade 5, but that's how I could show you how bad that one was. But you can see, once we started it, and I told you we had 46 babies. So this data is going past the end of the IRB, but I just wanted to show that we were able to continue our results afterwards. And then we did have one bleed here. It was an unfortunate birth at home. It's like we weren't there for the first part. It's not like a true testament to our bundle. But post-implementation from January 2016 until February 2018 was right before that other kid. The NICU has had a consistent rate of 0 severe IVH. So yes, so I was really, the team really jumped into this. I got a lot of, of course, you have those traditional nurses that don't want to buy into it. But everybody really took ownership. And, when it came to day 7 for the first ultrasound, everybody would can't wait to see what the result was. And they would come to me and like, I admitted that baby and it didn't have IVH. So it was almost like a competition. But it was good because I felt like if they were excited about it, then they're going to do it. And it was a good way for people to really come together when they saw that what their work was doing and how their work was changing patient outcomes. Bedside care, bedside management of a baby can prevent IVH. And I think that really made those nurses feel like they really wanted to put everything forward to this, that their efforts can show such great work and great results. So obviously, our data suggests that we should really standardize our nursing care practice for infants less than 30 weeks because we have zero IVH. And we continue to have to do PDSA cycles because we always fall into snags. Once we've been doing something for so long, things fall off the cracks, and we got to do something different. So we really want to make sure that people are more compliant with the bundle. I'm not there now, so I really hope people are keeping up with the bundle. I do get texts every now and then with people very excited that we had a 23-weeker with no bleeds. People are still going strong with it. And then I really wanted to increase family involvement in this, and how is that going to affect the metric of the patient and family experience? That was the next step that I was wanting to go towards, incorporating them into the bundle even more. Yes, we did incorporate them, but I wanted to take it to the next level. And I wanted them to create more of a better neuroprotective environment too, not just the nurses spouting out rules to mom and dad, like, don't do this, can't do this, do this. But have them be part of that neuroprotective environment and how they can be integrated into their baby's care as well. How can we have them decrease stimulation? And then how do the staff perceive stress in the NICU? And I don't mean ourselves stress, but the baby stress. How do they perceive it? Do they feel like some of the procedures that we do create stress or not? Really incorporating neuroprotection into this and having it in a different realm. If we can try to minimize the infant's exposure to pain and stress, think about those long-term outcomes and how that can affect the baby even further once we've established they didn't have IVH in the first 72 hours. Right before I left, we just started doing developmental rounding on the unit, which was very helpful. It was a good way to see what was going right, what was going wrong. And then we started creating bedside cards. So I worked with OT PT to do a card that we can put at the bedside to help parents interact and bond with their infant and different techniques. So it's really hard, it doesn't come out very well, but it's a nice little card that they can see different ways to contain me, give me firm touch, let them hold your hand, please be quiet, keep it dark. How many parents come in and throw open the cover and start yelling through the portholes? So these are different ways that we can do it. And it took us a long time to come up with this little saying. Most importantly, I need my sleep to grow, so please wait until I'm awake and ready to go. So that was a nice way to tell the parents to hands off for a little bit, let your baby sleep. So these were really good. This was very helpful. It was really well received by parents. It's a nice visual for them when OT or PT isn't there to help them or if we're busy with another patient. So this is my lovely team that helped work with me on this project. And I'm just very excited to be able to share this with everybody. So thank you to Kathy and the planning committee because it's just one person can make all the difference. And it's a bedside care practice. So just think of how much you can do to help your babies.
Wasn't that an amazing presentation from Jill? It's so much fun to see her and Mazal present this side by side at the One Conference in Orlando, Florida. So I'm going to just lead you straight in to the presentation by Mazal.
So what I will talk about is introduce the Israeli program Protect My Brain or Headkeepers, how we established a national committee to prevent IVH among preterm neonates. Then how we initiated the program among 28 NICUs in Israel. And then I will describe what we did in our NICU at Shemer Medical Center. Of course, no funding was received and no conflict of interest. Kathy talked about what motivated the project was one article that was published in 2016 that showed data about IVH in Israel. As you can see in the screen, the article was comparing between 8 developed countries, measuring outcomes of IVH, so in survival. Israel had the highest rate of severe IVH, more than 3 times compared to Japan. We wanted to do something about it. In 2017, we established a national committee made up with multi-professionals and interdisciplinary team, including neonatologists, head nurse, gynecologists, nurse practitioners, neurologists, and midwives. And the team worked on creating bundles, procedures in a number of domains, using the plan, do, check, and act model. Okay, so you see it's similar to what Jill was talking about. For the planning, we started by a vision, a goal of reducing IVH among preterm neonates between 24 till 28 plus 6 weeks, reducing by 50% within 3 years. We created 5 bundles, what we found in the literature and what we thought that would be most easy way to implement in the NICUs. One was antenatal steroids for high-risk pregnancy, delayed cord clamping, 60 seconds minimum, baby temperature above 36, gentle ventilation, and of course, minimal handling. We did semi-annual workshops to train doctors and all nurses and everyone that is involved, midwives, gynecologists, about the bundles, to teach them what to do. And we measured the information of 28 NICUs. We used the red cup to gather all the data and information. What we suggested for the 28 NICUs in Israel, how to implement the program in their NICUs. Of course, we are in different sizes, different ways of work. So everyone had to make up a program that is suitable for their place. They had to do a presentation of the process, make a simulation so that the teams can work and be better on what they do. If they had questions, they, of course, could ask the steering team and participate a monthly conference call between all the 28 NICUs if they had questions, to talk about the progress, what they have reached, what is missing, how they can improve themselves. Every 6 to 8 months, there were workshops held and they were given success stories, every NICU if they had. And a conference to share the progress and the success indicators for all the NICUs to learn and improve. This is an example of a dashboard that the committee has suggested. Of course, it's in Hebrew in every NICU. But you can see that it combines all the things you need to practice through all the process, starting from the delivery room and then the NICU. You can see here that there is an NRP diagram. What we believe that if you put this dashboard, you can see it and remember what to do. It's much easier. It's a visual tool. So what we did in our NICU, of course, we did our own local staff, including OR staff, midwives from the delivery room, a neurologist that is working with us, my NICU staff, including me and another nurse, ultrasound technician, and a neonatologist. This is the local team in our NICU. And we started by sharing knowledge about everyone that is relevant, because you need everyone to cooperate. It can't be successful in this program without cooperation. Jill said earlier that it's very challenging to persuade the OR team about the temperature in the room and about practice delayed cold cramping. You need the cooperation. So if you share the knowledge and you tell them why it's so important, it's much easier. You needed equipment. If we needed to keep the right temperature, you needed equipment. Jill talked about towels and warm place and sophisticated incubators to keep them warm. So we needed the management to buy the stuff. It wasn't so easy. And practice general skills. It's not easy to say and talk about something without practicing it. The doctors, for example, needed to know how to ventilate by volume targeted. We didn't ventilate by volume, so it took time for the doctors to know, for the nurses to know how to practice this gentle ventilation. This is one example. Another example is minimal handling, how you do everything in two people. You needed in a NICU that is short of a hand, you needed to take the parents, for example. I'm missing two hands, use the parents, use the physiotherapist, use everyone that is available to do the minimal handling. So you need to teach everyone. And of course, data collection. You need so many data to collect, as you saw earlier in the dashboard. And if you have a case, you investigate. We fill many checklists we have. If a baby was born, then you fill a checklist. You learn what we did good, what is missing. We learn from this, so we will be better the next time. The monthly meeting, we showed a data presentation, what was difficult, what was the opportunities. We focused on the interaction between the NICU and the OR and the delivery room. And of course, training the simulation for the team. We make many simulations, it's very helpful. Sometimes we had a simulation and the next day a preterm baby was born, so we were so happy that we practiced the day before. And of course, celebrating if the baby was with no IVH, it's so important. We also wait after 72 hours the first ultrasound, and we're very excited if there is no IVH. Here are some data from our NICU. As you can see, our numbers were even worse than what Jill showed in her NICU. It was way above the average in Israel, 27%. And as you can see, the earlier, the tinier the babies were, then the more they had the IVH. And in the end of 2019, after we initiated the program, we are starting to see much lower numbers. So we hope that in 2020, it will be even much better.
That's a wrap on this week's presentations with Jill Beck and Mazal Shemer. I hope that you enjoyed seeing the international global perspectives on IVH prevention. It really reminds us how many similarities there are between all the units across the world. We all have those things we need to work on. We all have those leaders in the unit who are willing to look at the data, pretty or not so pretty data, and they're willing to just step up and to be that one person who can lead out and make a difference in your unit. So I hope that these presentations from both ends of the world give you some inspiration and also some motivation to see what you can do in your nursery. Next week, we're going to have another presentation by another nurse practitioner who led out on an IVH prevention program in her unit, and we'll bring that to you right here on our YouTube channel on Monday, November 20th. If you'd like to get some of the resources mentioned in this presentation, download the slides, or just see the other replays from previous weeks in our series, go ahead and click the link in the show notes below or scan the QR code here on the screen. If you haven't already, and I don't know why you wouldn't, go ahead and hit that like and subscribe button. When you subscribe, it tells YouTube that you enjoy the videos we bring to you, and it will send you more from other NICU educators as well. It also helps us to be able to bring you more free content. So go ahead and click that like and subscribe button, and I will see you next time.